Hello guys, welcome to today's class. So this is one more MedEd Clinics. So this is one more clinical corner class. This is regarding to the examination of the shoulder joint, right? So we are coming in a series of examining all the joints. So we have done all, but this is our last joint for examination. That is your shoulder joint, right? So just makes things clear before we start. Audibility, visibility, everything is clear. Yes, I'm sorry I was delayed by 10 minutes. There was some iPad issue, so I have to solve that. Yes, should we start? Are we good? Yes, especially I want to know about the audio because the last few classes we had some glitch in the audio. So let me make sure before the start of the class that audio is quite audible to you all. Yeah, probably because we have completed all the joint examination. No, if you want anything else in particular, so the thing is now I have done a generalized details of all the joints. Like we have dealt about hip joint, elbow joint and all. If at all you want anything in detail, like for example, you want only to learn about a case of a malunion of distal radius, only that you want to learn, you can just text me so that we can add more and more classes. Okay, so shall we start if everything is fine? Chalo. So today is the examination of the shoulder joint. So to be very, very frank, I don't think they will ask you regarding the shoulder joint examination in the exam, right? They won't, probably they won't. Usually what we give you is the elbow joint for sure, and distal radius wrist joint also is one of the most important, and examination of peripheral nerves. So these three are the first ones, and then comes the examination of the diseased bone that I have told you regarding the chronic osteomyelitis or any tumor swelling cases. So that is the fourth. So this is the order which they usually pick up the cases. So 4 cases for sure. Then they will have the knee joint. Knee joint is also one of the most important joint, in the examinations. And shoulder joint, usually, the cases regarding the shoulder joint would be related to rotator cuff and maybe if at all there are no enough cases, no, then we'll add up the shoulder case. But usually shoulder case are least preferred. Okay, so let's not take that into consideration. Let us only assume that if at all there was some interesting case and you were supposed to take that case, because whenever you take something different from others, no, obviously the examiner will have that good impression on. Okay, so we are just learning to make a good impression regarding the shoulder joint. Okay, let's think that way. So coming to the shoulder joint. So what do you think would be most common causes where the patient would visit the OPD regarding the pain in the shoulder joint? So here, yeah, this would actually help in Viva. Very good. Yeah, it could, because whenever they talk about the X-rays, right? So whenever they speak about more about X-rays, no, then this will definitely come up. And it is one of the important topic also. Yes, dislocation is one thing, but usually they won't give you the dislocation as the case, but they can put that as the X-ray option, right? So this dislocation can be an X-ray option for you. Okay, but in the OPD, what I'm saying is the chronic cases. What are the most chronic cases which you see in the shoulder joint? So usually what they come is, probably they will come with the pain in the shoulder joint. And the most common complaint regarding the shoulder joint is restriction in the movement. So now our shoulder joint is a ball and socket joint. We all know that. And this ball and socket joint enjoys a variety of freedom of movements, right? Your circumduction movements it enjoys this. And the most common complaint, especially in the OPD, what we see is this restriction in the movements of the shoulder joint associated with the pain. This is one of the chronic complaints. Like acute is usually the most common acute condition, as you already mentioned. It is the shoulder dislocation. That is also the anterior, which is more common, right? The anterior shoulder dislocation is the most common one. Agreed, yes. Good afternoon, Jesus, but here in our place it is almost 8:48, so good evening would be more appropriate. But according to your climate conditions, good afternoon is also okay for us. So now today we are dealing with shoulder examination. As I've told you, we have just started. We have done with the most common complaints in the shoulder, that is the pain and the restricted in the movements. That is mostly the chronic cases I have told them. And when it comes to acute cases, that is whenever it is related to some trauma in the shoulder, the most common traumatic condition would be this shoulder dislocation. Okay, we are going to also learn about the little bit of shoulder dislocation also today. Right? And now what I want to actually tell you is regarding the shoulder, most of the pains have sometimes will be a referred pain from the neck. So for example, your cervical spondylosis will radiate the pain to the shoulder. Right? So you have to be very, very careful whenever you're dealing with a patient who is presenting you with the shoulder pain, and you have to make sure that this pain is arising from the shoulder joint itself. So there is one more possibility, that is it could arise from the cervical pain, and this could be a referred pain, right? A referred pain, that is a radiating pain or a referred pain from the cervical area. So you have to be very, very careful. And how do you differentiate between whether this is from the shoulder joint or from the cervical spine? So let us quickly. So the first one, if it is from the shoulder, if it is from the C-spine, no, it is usually associated from the nape of the neck. So patient will tell you that the pain starts from the nape of the neck, that is little above the shoulder. This level the pain starts. It is usually not in this level the pain starts. And she tells that it is radiating down and often associated with what? With your tingling and numbness. Yeah, it is probably the shooting type of pain. You know, you can think this is somewhat neuropathy, right? And then if it is a shoulder pain, usually they say it is pain and they point towards shoulder and the movements. So the movements will be restricted, right? The movements will be restricted or the movements would be painful, right? So these are the some of the important things. You know, this was the actually question which was asked to me in my viva. So how do you differentiate a pain from, you know, C-spine and a shoulder pain? Okay, this was the question which was asked to me during the viva. Okay, so this is what I have told, and that is how you actually differentiate between a C-spine and the shoulder pain. Okay, so that is the first thing I want you all to clear. And then, yes, anytime you're talking about orthopedic cases, always remember that the functional limitation plays a very, very important role. So you have to always ask them what is their actual symptom, whether this is a pain which is actually, you know, bothering them, or it is some restricted movements, or actually the functional limitation. So these functional limitations are again related to any pathology in the shoulder joint, right? Like, so for example, combing their hair, you know, they have to rotate like this and they have to comb, buttoning and unbuttoning the shirts, and you know, doing their daily household chores, especially the female. So you have to always take what are the activities which they are facing difficulties, right? And if you're talking about you know, dislocations, recurrent dislocations, if it is a chronic case of recurrent dislocations, Then you can ask them, how many episodes and what was the treatment protocol they have followed. Right, so this will be your history taking. So you all very well know what you have to ask in the pain, right? You will ask the pain, you have asked the onset, the duration, right, and the radiation. So pain, what will you ask? You actually start asking with onset, then you will ask the duration, right, and then you will talk about the radiation, whether it is radiating, and associated symptoms, right? And then you will ask about restriction of movements. So in that also again you will add the functional limitation, right? So these are the main things which we take in the history. So this is mainly the history, and you have to always be sure that it is not radiating from the C-spine. So C-spine and the shoulder you have to differentiate by the end of the history itself, right? Then only you will go into the examination. So that is about your history taking in case of your shoulder joint, right? And then let's move on to the clinical examination. So once we are done that, we are very sure that this is the patient who has come to us with some problem or some pathology in the shoulder joint. And by the history, we are sure that there is some pain which is related, and there is some restriction of movement, and there are some functional limitations, right? And you have to actually make sure that this is not the case which we are dealing with polyarthritis, because it is again another criteria. So you have to always inquire about the other joints, right? Other joints involvement, and not make sure that it is not dealing with TB. So you will add two important things, that is loss of weight and loss of appetite. And you very well know if it is a trauma, then you are very much interested to ask about the mechanism of the injury, right? So how did actually the trauma had occurred, right? For example, if you're dealing with any fracture humerus case or fracture clavicle case, then you will ask the mechanism of the injury. And usually trauma cases are easy to deal with, because they directly tell you that so and so injury had happened and this has resulted in so and so thing. So there's no much of history taking in case of trauma, right? So this is how we end up our history taking, and then we move on to our clinical examination. So once we are very much pretty sure that it is the shoulder joint which is actually bothering the patient, then you have to start examination of your shoulder joint. So whenever you're examining a joint, what is the first thing you do? Yes, these are the two important things which you have to do before entering into any examination. So what are the two things? Yes. A generalized thing, not related only to shoulder, not related only to orthopedics, but a generalized concept of, starting your examination. So if somebody is really planning to do MRCS after your MS in India, so this is the OSCE things they ask you there. So very, very important. Hey, I'm asking the examination, I have not entered into palpation yet. I'm still in the just started the examination. So we have just completed the history taking, and now what is the first thing you do? Now we're going to touch the patient, we're going to see the patient all around. So what is the first thing you do? Yes, Zeus Khan. Med student. So the first thing what we have to always do is take the consent, right? You have to always take the consent. The introduction of yourself will be done before history taking itself. But when it comes to clinical examination, you're going to explain the patient. You're going to look, feel and move, that we're going to do. But before that, you have to take the consent of the patient and proper exposure. So you are going to explain the patient what we are actually going to do, that we are going to examine the patient, and which is the joint we are going to examine, and what is all this examination involves about. Like you can tell them in a simple terminology, like Zeus has told us, that we can look, feel and move. So we are going to tell them that we are going to look your joint and look at the shoulder joint. We're going to feel it by palpation and we're going to move it. So this is what we are going to do, and for that we require permission, right? And then you properly remove the shed so that it is properly exposed directly from the neck up to the waist at least. And then you have to inspect the joints, comparing it to the both the sides. So in ortho we are lucky to have everything, you know, in twos, like we have bilateral shoulder joints, so that is why you have to always compare. And when coming to the inspection, palpation, measurements and movements, so this is the order, right? Inspection, then you go for palpation, then you go for movements, then you go for measurement. So this is the order which we follow in ortho. So in the inspection, what is the first thing you do? So inspection I have given here already, because I want this to put in your mind, you know, whenever you think about inspection, these all should flash in your mind. So I have put together. So first one is very, very important. You all know that is your attitude. So what is an attitude? What is a deformity? So here we can actually talk whether it is an attitude or a deformity. So what is an attitude? Med student? Yes? I keep on telling in every class what is an attitude. These are the questions they usually put in the exam also. We will learn for all big things, and if you don't answer these basic things, no, they will get pissed off. So what do you think is the definition of an attitude? Yes, it is the position of the ease. So just tell attitude is nothing but position of ease. Yeah, you can also tell it is the position of rest. And what is the main difference between the attitude on and the deformity? So it is a position of the rest. Yes, but can it be easily corrected? So this is a very good statement, position of ease, but you have to add something else which will impress the examiner. So which can be corrected. But what is a deformity? This is another type of position which cannot be corrected by the patient. And it always requires a surgical correction. Deformity always requires surgical correction. Does attitude require surgical correction? No, right? So that is what is the entire definition. So position of the ease of the patient or position of the rest, but which can be usually can be corrected if it is a wrong position, right? So what is the main thing you have to learn in this attitude? So here, whenever we come to the shoulder joint, what is the most important thing is that the contour. So next we are going to learn about the contour. So if you see any person, you will understand. Okay, just excuse me. Headache of the humerus? Yeah, yeah, it is not exactly because the rounded shape of the head of the humerus. So there are two important things which will lead to this contour of the shoulder joint. So the first one would be So the first one would be your the greater tuberosity, the protuberance or the protrusion of the greater tuberosity, little bit front to compared to your acromion, right? So compared to the acromion, you can feel that greater tuberosity is present, and then and the second one is because of the deltoid, and second one is because of the deltoid. This is the actually problem, something with the iPad today, troubling me. So these are the two important things. So first is the presence of the greater tuberosity and the GT in relation to the acromion, and the second one is your deltoid muscle, the orientation of the deltoid muscle. So these two are the important things which will actually, make us feel that the contour of your shoulder joint. So whenever there is an anterior or any dislocation, I'll just come, just give me 1 minute. I'm extremely sorry for that interruption. I don't know. Today only it is troubling me for the first time. It has never has given me such a trouble. So that is regarding the counter and the so the mainly what you have to look for is for the shoulder joint, and this examination of the shoulder joint you're going to look from the behind and from the front and from the sides. So this is how you have to do the inspection, right? And in the inspection, the first thing what you have to note is that uh, the counter first and then the flattening, which is also called as the flattening. I have told you that this is because of the greater tuberosity in relation to the acromion and the deltoid. So if there is any deltoid paralysis also, you will see that flattening. And if there is any problem in the fracture, that it could be a fracture of the humerus, that is in the you have fracture of the head of the humerus, and sometimes the fracture of the clavicle will also result in this drooping of the shoulder or the loss of that contour of the shoulder. Okay, loss of that contour of the shoulder. And then The most important thing is the next one. Again, once you see this, the compare the flattening of the shoulder to the opposite side, and now you have to look for the attitude. If it is the case of your anterior dislocation of the shoulder, how do you think the patient will come to your OPD? So how do you think that patient will come to your OPD? So this case, whenever there is any problem in the shoulder, it could be a fracture clavicle, or it could be, the dislocation of the shoulder. What will actually happen is the patient will hold in the opposite hand. So this is the position which I was asking you. So this is, they will take the help of the opposite hand, and this is how they hold and they come near you. So this is the picture, right? So this is the picture where you can see that the contour is lost. You can see that there is a flattening of the shoulder, right? And then the patient is coming with the help of the other hand, is taking the help of the other hand, right? And what is this? What is this position? Second. So this one is the adduction position which the patient has brought. So it's completely towards it, right? Then what is this? The second one. The second one. So this is called the hyperabduction position. So this is your hyperabduction position. So this hyperabduction position is usually seen, yeah, luxatio erratica. Very good. Yes, it is luxatio erecta. So in this luxatio erecta, what happens is, because of the hyperabduction of the shoulder, there would be the inferior dislocation. So this is the inferior dislocation, which the patient comes up with the OPD. So they will have hyperabduction position, and this is the inferior dislocation, and this is luxatio erecta. Yes. So that is about your attitude. Then that is about your deformities. So this attitude is one where the patient comes with the position of the ease, right? And sometimes the patient, usually, in the shoulder joint, we will not find any great deformities. Like, so the deformities are usually seen in the elbow, that is cubitus valgus and cubitus varus. And next thing what you have to look for is any swellings around the shoulder joint. So you can see if there is any dislocation, you can see that there is, a swelling on the anterior aspect. You can see rounded bony swelling in the anterior aspect. So that is in case of dislocation. So any other swellings other than that, you have to look for in case of inspection. And the third one, and so we have done with deformity, attitude, then counter, then swellings, and the fourth one is your skin. So anytime on the inspection, what is main important is the skin over that particular area. So you can find there would be any bruise, or there could be any scars which might lead to the diagnosis. So these are all small telltale signs for you to do the diagnosis. So this is very, very important. You look for the skin over the swelling also. Skin over the swelling or skin over the joint, right? And then, so that is about the inspection. So this is about the inspection. You're going to tell in detail whatever you're going to look for there. Yeah, right? And then comes the palpation. So in the palpation, what is most important thing is you're going to confirm all the inspectory findings. So you're going to confirm all the inspectory findings, right? So that is how we are done with the inspection. And then we are dealing with the palpation. So what is the main thing in palpation? Anterior dislocation is the most common. The treatment would be for any dislocation. The treatment is reduction. You have to go for immediate reduction. So anterior dislocation is a condition where the mechanism of injury is abduction and external rotation, right? So whenever you abduct and external rotate, there would be an anterior dislocation, right? And how do you treat it? You will treat it by immediate reduction under anesthesia. So before they used to do all types of gimmicks without giving anesthesia, but now the research has proved that anesthesia is very, very important for reduction. So how do you reduce it? First, you take the patient to the OT, give anesthesia. That is usually the general anesthesia we give. And what we do is we do traction and then we reduce it. So traction, what is the mnemonic for it? We remember it as TEAI, right? So we will do traction, external rotation, adduction and internal. So that is how we reduce the anterior dislocation. So once you reduce it with the maneuver, so this is traction, then you do slight bit of external rotation, right? Then you do adduction and then internal. So once you internal rotate it, the main thing is this particular uh, hand or the affected shoulder joint, the hand of the affected shoulder joint should touch the opposite shoulder. So once you do adduction and internal rotation, so it will just give a click sound and you can touch the opposite shoulder. So that is how you confirm that there is the anterior dislocation has been reduced, and soon after that you will go for immobilization. So immobilization is by your, again you will use the shoulder immobilizer, that you have to bring it before reduction. So once you reduce, you immediately put the patient in shoulder immobilizer for at least 3 to 4 weeks, right? So once you're done with 3 weeks period, then you can slowly start the movements, right? So this is about the treatment of the anterior dislocation of the shoulder. Okay. So once you are done with the inspection, then now you're heading towards the palpation. So as med student has told us before, in palpation, what is the most important thing we look for? The first one would be, so first one is again proper exposure. We have already done by inspection. So in palpation, it is mainly by, you will confirm all the inspectory findings, right? You're going to confirm all the inspectory findings, and then you will always look for any rise in temperature, right? And the tenderness. So for looking for this tenderness, what do? You have to actually palpate the bony structures. So what are the structures which are forming the shoulder joint? Can you name them? The first and foremost is your head of the humerus, right? Your head of the humerus sitting in the glenoid. Head of the humerus which sits in the glenoid, right? And then what are the bony prominence which you see around? So the next bony prominence what we look for is your acromion, right? So acromion, then your clavicle, usually the lateral end of the clavicle, and then your coracoid process. So this is all the things which you have to palpate in case of the shoulder joint. So you're going to palpate entire clavicle. So this is the clavicle, and if you remember, the clavicle makes two important joints. So one with the sternum, which is called as a sternoclavicular joint here, and then as you go and palpate like this, you can find that there is a little bit of prominence again. So that is your acromioclavicular. So this is sternoclavicular and this is your acromioclavicular. And now palpation of the clavicle is very, very important. How do you do that? You actually palpate the clavicle. You have to go behind the patient and then you're going to start from the sternoclavicle. So once you palpate like this, you can feel that there is hardness here. That is your sternum, and this is your clavicle, which is forming the sternoclavicular joint. So you're going to palpate that and you look for any tenderness there, and then you're going to palpate the entire length of the clavicles on both the sides simultaneously until you reach the lateral end where it is making another joint with the acromion. So this is the acromioclavicular joint and this is your sternoclavicular joint. So this is your entire clavicle. So whenever a patient comes with a clavicle fracture, you can easily palpate the fracture. right? And where is the, after palpating the coracoid, so this is the length of the clavicle we have palpated, and now we are going to document about it. So there is no tenderness over the sternoclavicular, the entire length of the clavicle felt, and there is no abnormality like the bony irregularity or any fractures or any tenderness, any swellings are not felt along the entire length of the clavicle. So that would be your statement. So once you are done with the acromioclavicle also, so whenever there is sternoclavicular dislocation, so what are the two important things here? So one is your sternoclavicular dislocation. So sternoclavicular dislocation is usually anterior side, so easily you can feel them on palpation. But when it comes to acromioclavicular dislocation, it is usually superior, right? So it moves like that. The acromion moves up in superior. So you can feel that there is gap between your acromion and the clavicle. So the gap gets increased between acromion and the clavicle. So that is your acromioclavicular dislocation. So these two are important things. So both the dislocations and the entire length of the clavicle. That is regarding the clavicle, the bony structure which is regarding your clavicle, right? And then comes the next bony point is your coracoid process. So where is the coracoid process? It is exactly ½ inch below the medial 2/3 and lateral 1/3 of the clavicle. So you will palpate the medial 2/3. So this is your medial 2/3 and then your lateral 1/3. So exactly below that, ½ inch below your clavicle, you will find one more bony structure, which is, you can just palpate there and you will feel that is your coracoid process. So coracoid process also usually we feel for any tenderness. We feel for any tenderness at the coracoid process, right? So that is the coracoid process. Then what you do is, then you go back again to the lateral end of the clavicle and then just move below. So below again, you can feel for the greater tuberosity of the humerus. So you have to palpate for the greater tuberosity of the humerus. So this is what I was explaining. So now, so first we had done with the head of the humerus. So usually this humerus head on the glenoid cavity, this is all we usually palpate it by movement, right? But on rest, you will feel for the, as we have told you, the length of the clavicle. So this is your sternoclavicular joint here, and this is your acromioclavicular joint, right? And then I have told you ½ inch below, this is the medial 2/3 and lateral 1/3. What you feel is your coracoid process. So this is your coracoid process which you're looking for, right? And once this coracoid process is felt, then you look for what is called the greater tuberosity. So this is your greater tuberosity, right? So you will look for the greater tuberosity and then you will feel for entire length of shaft of the humerus. So up to maybe still here you can feel, because we are examining the shoulder joint. So once you feel for the greater tuberosity and then you will go a little down. So you feel for the both, one is the anatomical neck of the humerus and then the surgical neck of the humerus. So these two also you can palpate, right, for knowing the fractures. So whenever there is a problem in any of this, whenever they are not oriented, this could be because of the ligaments which are present around the shoulder joint. So let us have one word regarding the ligaments around the shoulder joint. So the first one is so if you see here, there is a coracoclavicular ligament and then there is acromioclavicular ligament. So this AC joint and CC ligaments, right? And you already know there are glenohumeral ligaments, like glenohumeral, or there are ligaments which are covering your shoulder joints. So coming to the AC ligaments and CC ligaments. So whenever there is an AC joint dislocation, you very well know that these ligaments are disrupted. So what are those ligaments? So are there two. One is your coracoclavicular ligament and the second one is a acromioclavicular. And if you remember, the CC ligaments are again of two types, the trapezoid and the conoid. The conoid ligament and the trapezoid ligament. Are you able to follow? Yeah, that is the problem. This iPad is really giving me a tough time today. I'm just sorry, guys. I don't know what had happened to the iPad. Same issue was there before I started the class, but I thought got rectified. But give me 5 minutes. So that is about the palpation of the clavicle, your AC joint, and the clavicular joint, and then comes your humerus. I've told you that you're going to palpate, and next is the most important thing which we are not going to forget. That is the spine of the scapula. So once we are done So once we are done with the palpation, then we have to always examine the scapula. So scapula forms a very, very important role in the shoulder joint, and it is very important for the movements of the shoulder joint, right? So how do you palpate the spine of the scapula? So this is what I wanted you to tell. That is how we do the examination of the clavicle. So clavicle, we are going to go back from behind, and then you're going to first start with the your sternocleidomastoid, and then you're going to palpate it around bilaterally on the same side. So that is your palpation of the clavicle. Then comes the palpation of the AC joint, right? So once we are done with the AC joint, and then I've told you that you're going to move downwards with the help of the greater tuberosity. You can even palpate the bicipital groove, and with the rotations you can also feel it, right? So with the rotations you can feel the bicipital groove. So this is how you palpate the bicipital groove. And after done with this too, then we are going to actually palpate the spine of the scapula. So spine of the scapula also, what you're going to do, you're going to start it from behind because it is on the posterior aspect. So you're going to first palpate the scapula. The scapula, the most prominent parts are, the first is the acromion, right? So the acromion is very much palpable, subcutaneous, and then comes the spine of the scapula. So it is behind spine of the scapula. So you're going to palpate that, and then the vertebral area of the scapula is almost most prominent, and you can feel it more when compared to your axillary part. The axillary part is more of muscular, so it is usually covered by muscles, not very much palpated. But what you can do is you can always palpate the vertebral aspect of it, that is the medial border of the scapula, right? So scapular palpation is very, very important. And once the iPad comes back, I'll tell you the spine. So you're going to actually palpate the spine of the scapula. And again, how do you palpate it? So you go back and then you palpate the spine from the most prominent border. So you can also do that. So once you palpate the acromion, then you can go along with that, that is the spine, or else from the vertebral medial border also you can palpate it, right? You can palpate it. So that is for spine. Here also you can feel for tenderness, you can feel for the movements. So once so this is how you have to go for actually palpating the spine. So you are going to touch the most prominent area there, and always remember that so this part is actually more prominent and you can feel it more clearly than your axillary part. That is what I was explaining. And this is the spine of the scapula. So this you will palpate in this particular order, right? So you will feel for any tenderness there, or any abnormality or bone irregularity or any extra growth. So this all you will feel for the spine of the scapula. So this is how we will examine for this clavicle. Then we will examine for the acromion, and then we will go for the humerus, and then finally the spine of the scapula. So this is how you are going to measure it, right? And then all the palpatory findings you're going to document. So whatever is the finding that you have come up with, in the clavicle part, and then in your scapula part, you're going to write it in the document. And then there is also, as we have learned, there are some bony relationships. Like in case of elbow, we have 3-point bony relationship, right? And in case of hip, we have learned there is a Bryan's triangle. So similarly, in the shoulder also, we have some 3-point relationship. So what is the 3-point relationship? So here what we take is the tip of the coracoid, and then we take the acromion. So this is the acromion first, and then the tip of the coracoid, and then your GT, that is your greater tuberosity. So this relationship also you can compare. So this is also a 3-point bony relationship, which you can compare it on the both the sides. So one would be your acromion, tip of the coracoid, and tip of the GT. So these three are the bony relationship prominent findings which you can see on the both the sides comparatively. So whenever there is any problem, that if at all it is an AC dislocation which we are discussing, so there could be decrease in the distance between acromion and the increase in the distance, or AC joint is increase in the distance between your acromion and the greater tuberosity, right? So this is the 3-point bony relationship. So in palpation, you're going to palpate all the bony structures, and then you are going to examine about this 3-point bony relationship, right? Then once the palpation is done, then we are going towards the movements. And similarly, if in the palpation also, if there are any swellings, then you will again go for examining the swelling. So the swellings you will examine again, you know how to examine a swelling. So similar way, you will examine those swellings which are present in case of palpation. Then next, after palpation is very important movements. So movements are very, very important in case of shoulder joint, because there are vast number of movements, and the shoulder joint it enjoys a very great freedom of the movements, right? So what are those movements in the shoulder joint? Yes. Let's not get distracted with the iPad. So what are those important movements in the shoulder joint? So in the frontal plane it is, that is the sagittal. So the first one we move is the flexion and the extension, right? So flexion and the extension in the sagittal plane. Then in the coronal plane it is abduction and adduction, right? And then we have your external rotation and internal rotation. So put all together we have the circumduction. So these are the movements I was talking about. So flexion, extension, abduction, adduction, external rotation and internal rotation, right? So these are the movements of the shoulder joints, and these are basically because of the glenohumeral movement, and there is also some amount of scapula which is contributing to this movement. So you have to always be careful. Yes, now we will not have any problem. Yeah, sorry. The problem is rectified. So now the thing is, now we are at the movements of the shoulder joint, right? In the movements of the shoulder joint, I have told you that there are set of the movements which you have to examine. So first is the sagittal, that is flexion and the extension. So moving forward and backward, this is flexion and extension, right? And then we have your abduction. So this is your abduction, exactly 180 degrees. So we're in straight line, 180 degrees abduction, and then this is your adduction. Then this is your external rotation, and this is your internal rotation. So this is all the movements which we see in case of your shoulder joint. So what you have to remember is here the shoulder joint movements. The scapula also plays a very important role in case of your shoulder joint movements, that you have to be very, very careful, right? So whenever you're abducting, so initial abduction is by a glenohumeral, but later abduction, there is some movement in the scapula. So you have to know whether this is a glenohumeral movement or a scapular movement. So you can, for that, what you have to do is you have to hold the scapula. So you have to make the scapula not to move, that you have to hold the scapula, making it not to move. Then you are going to test for your glenohumeral movement, right? So this is how you have to test for it. And as you all know that movements are again of two types, right? So there are active movements and then there are passive. Active movements and passive movements, right? And then what you have to remember, always remember, there are two important joints here, and then your scapular. So movements occur because of glenohumeral involvement and the scapula, right? So every 15 degrees, there is 10 degrees of glenohumeral and 5 degrees of scapular movements, right? This is what you have to remember. So whenever you want to test the glenohumeral individually, then you have to stabilize the scapula, right? To test the glenohumeral joint. Yes. Yes, is that clear? Anything? Guys, now I promise that you are not going to have any iPad problem. I have cleared the problem. We are going to concentrate only on the topic now. Okay? Sorry for that inconvenience. So now tell me, what would be the flexion? What is the range of the flexion? So they will ask you the range of the flexion. So flexion is about How much did I tell you flexion is? Yes, flexion is about 90 degrees and abduction is about 180 degrees, right? And then extension is about 45 degrees, right? And internal rotation and external rotation, you can see the internal rotation is slightly lesser compared to the external rotation, right? So external rotation is about, again this is also about 45 degrees and this is about 30 degrees. Okay, okay, so these are the various movements. So what do you think is one of the most important disease? So for example, in case of your frozen shoulder, so what is a frozen shoulder? So what is a frozen shoulder? So here what happens in case of frozen shoulder is the joint capsule, the shoulder joint capsule gets shrinked, right? It gets shrinked, and because of that all the movements will be restricted. So this is called the global restriction. Global means all the movements. So whenever there is a global restriction of the movements, both active and passive, then you call this as the frozen shoulder. That is the, whatever the joint capsule, whatever the shoulder joint is enclosed in a capsule, so that capsule gets shrinked. So then the movements cannot occur. So that is the frozen shoulder. So in whom we usually see this frozen shoulder? Usually seen in, yes, come back now, answer. Frozen shoulder is usually seen in, yes, Khan, med student. In which set of patients we usually see this frozen shoulder? So it is usually seen in case of your diabetics, right? Diabetic patients. It is usually seen in diabetic patients, right? So frozen shoulder is usually seen in diabetic patients. It is one of the conditions where the patient will have restricted movements, right? And then once we have documented whatever the movements are present in the patient, then we are going about the measurements. So measurements, how we are going to measure? So we are going to measure the length of the arm. So here again the tip of the acromion to the tip of the lateral condyle of humerus. Right, so this is the measurement. So this is the measurement what we are going to take, right? And we are going to also measure the circumference of the arm, right? This is for muscle wasting. This is for any muscle wasting. And you can also measure the vertical circumference of the axilla. So this is usually what they tell is in case of your dislocations, anterior dislocation, this is useful for us. So the vertical circumference of the axilla. Of axilla, it is mainly useful in case of your dislocation, right? So these are the measurements. So length of the arm is from tip of the acromion to the tip of the lateral condyle, and then we are going to measure the vertical circumference of the axilla and then the circumference of the arm. This is mainly for the muscle wasting. So these are the measurements. But do you think these measurements actually play a role for us as they do in case of your lower limb? So in case of lower limb, it is very important. The length measurement is very important. Why? Because the two limbs are connected by pelvis. So here the two limbs are connected by pelvis, and if one limb is affected, the other limb also will be affected, right? But in case of upper limb, in case of your upper limb, because they are individual, so usually does not affect. Usually does not affect. Even there is a slight difference in the measurements of the length, that this doesn't put any effect for us, right? So that is about the measurements. Okay, so now we have completed the inspection, palpation, then we have done the movements and then the measurements, right? So this is how you take the case. So now let us see what is the painful arc syndrome. What is a painful arc syndrome? So here what happens is the patient will have pain only during certain movement of the certain range of movement of shoulder. So initially what will happen is the initial abduction, what is there is painless, and then once he goes to 60 to 120 degrees of abduction, then it is painful, right? And again after 120 it becomes painless. So this is one of the most important question usually they will ask you whenever they're talking about the movements. So this is the painful arc syndrome, and it is mainly seen in case of the swimmers. And the reason could be because of any subacromial bursitis or any problem in, abduction, the biceps tendinitis, and all this reasons could be there for this painful arc syndrome, right? So once we are done with this, we have to always go for special test. So that one thing I wanted to discuss, because they will ask you in case of your movements. And then coming to the special test in case of your shoulder joint, before that you have to learn about the rotator cuff. So what are the muscles of rotator cuff? Yes, what are the rotator cuff muscles? It is the first one, the supraspinatus, infraspinatus, the teres minor, and the subscapularis, right? Yes, so these are four important rotator cuff muscles. So four important rotator cuff muscles, and your shoulder examination will not be done if you're not completed examining this four rotator cuff muscles. So what are the four rotator cuff muscles? And what are the actions of this muscle? That is very important. So coming to the supraspinatus, the action is abduction. That is also initial abduction, right? And then your subscapularis, yes, internal rotation. And infraspinatus and teres minor are for your external rotation. So this is what you have to remember in case of your rotator cuff muscles, right? So what is drop arm sign? What is drop arm sign? Yes. What is a drop arm sign? A drop arm sign is usually seen in case of your supraspinatus tear, right? So whenever there is a supraspinatus involvement and whenever there is a tear of the supraspinatus, then you will see what is called as the drop arm. Right? And then empty can. So drop arm is nothing but you're asking the patient to hold the hand in air like this. So this is the holding of hand in the air. And if the patient is unable to hold the hand for maybe some 15 to 20 seconds, and then they will drop because the supraspinatus tear is there and they're unable to hold the hand. So this is called as the drop arm sign. So what is an empty can test? Again, this is also for test for the supraspinatus. So this is what is the can. Now we're going to empty it. So this is your empty can test. And now the patient is going to put this position and you ask the patient to abduct the arm against resistance. So abducting the arm against the resistant. So that is your empty can test. Right? That is also for the tear in the supraspinatus again. Then so next is your very important, that is your subscapularis. So what are all the tests you have for subscapularis? So subscapularis, I have told you, it is mainly for the internal rotation. The first one what we have is the belly press test, right? Belly press test and lift off test, right? Belly press and lift off, these two are very important. This is also called as the Gerber's lift off test. So what you do, you internal rotate it like that and you will ask the patient. So this is how you do the lift off test. So this is like the back side. So now you're putting internal rotation and then you are asking the patient to lift your hand against the back. So that is the lift off test. So this is done internal rotated, put your hand at the back like this. And when you put the hand at the back and then you're trying to lift off the hand. So that is the lift off test. And belly presses, you're going to put both your palms on the belly button and you're going to press it. So this is the belly press test. And the second one, it is also called as the bear hug. Bear hug, belly press or lift off test. So these three are, the test for your subscapularis. And then what is left out? Your external rotators. So that is your teres minor and infraspinatus. So what is these two for? Your external rotation. So you are going to ask the patient to external rotate against resistance, and whenever there is some lag, then you call it as the lag sign. So external rotation lag sign, that is seen in case of your teres minor and infraspinatus. So these two are very important. So one is your drop arm sign or empty can test, then your belly press, bear hug, lift off, and then your teres minor and your infraspinatus for your lag sign. So lag sign is you ask for the external rotation, and then they will do the external rotation. And whenever they are unable to do external rotation, when you compare to the opposite shoulder, then that is called as lag sign, external rotation lag sign. That is again will tell you that there is some problem in the teres minor or the infraspinatus, right? So that is about the special test which we are going to learn in case of your shoulder joint. So this is mainly for the rotator cuff muscles. So rotator cuff muscles, okay? Understood? Any doubt in examination of the rotator cuff muscles? Yes. Yes, is that clear? And now a little bit of the dislocation we will learn, because this again they will ask you. So coming to the dislocation of the shoulder, the most common joint which is to be dislocated, can be dislocated, is your shoulder joint. And in the shoulder joint, what is the most common type? So there are three types: anterior, posterior, and inferior, right? So the most common is, yes, very good, shoulder is the most common. Yes. And in the anterior, the subcoracoid is supposed to be the most common. Posterior, no, anterior is most common. Posterior dislocation is common in the hip joint. In the shoulder joint, it is anterior dislocation which is most common. Yes. And then in the anterior, again, we have another variety, that is subcoracoid. So now your exactly the humerus will sit below the coracoid. That is your subcoracoid, which is again the most common, right? So this is what you have to remember. And what is the mechanism of injury? So mechanism of injury, you have to remember that this, for anterior dislocation, there would be abduction and external rotation. So the patient goes abduction and then external rotate, so that the head comes forward. So head comes forward. So that is your anterior dislocation, right? So that is your anterior dislocation, right? And you know, for inferior, I have already told you. So what is the mechanism here? It is hyper abduction, right? And posterior, it would be adduction and internal rotation, right? So these are the mechanism of the injury by which the injury occurs, and now this will result in so and so respective dislocation. So these are the mechanism of the injuries, right? And then what you have to remember here is, so you will go for x-rays. And what is the sign which we see on the posterior dislocation of the shoulder? So in the x-ray, the posterior dislocation is very, very important. The sign which we see is, what is the sign called? Faster. So that is your light bulb sign. So that is your light bulb sign. That is especially for the posterior dislocation. And what you have to remember, yes, and what you have to remember is, this is usually seen in patients of epileptics and current shock, right? In case of epileptics and current shock, right? So usually those patients we will suspect the posterior dislocation, right? So that is how you have to remember the posterior dislocations. And what is the treatment for any dislocation? So you have to go for immediate reduction. Immediate reduction. It is very, very important. And I have told you that it is done under anesthesia, right? So here I have told you that traction, yes, external rotation, adduction, not abduction here, adduction and internal rotation. So we usually remember, right? This is how we do the, so traction, external rotated, then you adduct it, and then you internal rotate it. So that is how you will reduce it. And then you give shoulder immobilizer for 3 weeks, right? 3 weeks you go for shoulder immobilizer. Anything, all the reductions, it is the same, right? You have to go for immediate reduction, and for this the maneuvers are very, very important. And what is the one test for anterior dislocation you have to remember? Test for anterior dislocation. So what are those tests you will remember? The first one is, yes, it is the Dugas test. Very good. So what is Dugas test? I have already told you. So Dugas test is, you have to touch the opposite shoulder. So this, if you say this is my hand, the hand which I have, the pen is the affected hand. So you will make the patient to touch the opposite shoulder, right? If the patient is unable to touch the opposite shoulder, touch opposite shoulder, that means he's unable to adduct, right? So it is unable to adduct. So this is confirmation for dislocation, right? So whenever you see a patient in the casualty, what is the simple test you do? So that the patient, you can rule out the dislocation. So you do the Dugas test. So you will ask the patient to touch the opposite shoulder, and whenever he is unable to do so, then you can go for the X-ray, stating that it could be a case of, you know, anterior dislocation. So that is Dugas test. And then the next one is Hamilton ruler test. So this is obsolete now. So usually what they do, they measure the distance. So as we have discussed in the measurements itself, so whenever there is dislocation, the distance will be reduced. So the scale cannot be put across. So that is your Hamilton ruler test, right? And next is Calaves test. Calaves is, again we have discussed, that is about your axillary circumference. So that is your axillary circumference. So these are the tests which you have to remember for anterior dislocation, and this is the theory which they can ask you on the X-ray. So they will put the X-ray and they can ask you, is this a sign for anterior or posterior dislocation, right? So inferior is very easy. You can see that the patient will be in hyperabduction, right? So that is your inferior dislocation, which is also called as luxatio erecta, right? So that is about your dislocation, and we have discussed about the rotator cuff dislocation. So these are the usually the points which they ask you in case of your shoulder joint, right? So I think that's it. Anything else you want to learn and you want to know? Yes. So these are mainly the things which you have to remember, right? So these are the main important things, and then you go for the X-ray. So they will ask you regarding the X-ray to identify whatever is the thing in the X-ray, right? And then you will tell the final diagnosis. That is how we complete the case of the shoulder joint, right? And These are the important things. So usually, as I have mentioned in the first line itself, so this is mainly I am taking this because they will ask you a lot of, in Viva. That is very, very important. So usually shoulder cases a little minimal. I hope I've covered everything, even though we had jig in between. So this is about the palpation. So let me write, because again I have to send it the PDF. So this is the clavicle examination, always behind the back, right? Always from behind, and bilateral palpation you have to do on the both the sides, right? So this is very, very important. Then you're going to test about the bicipital groove. This is what we are testing. That is nothing but you go down, that is feel for the GT, that is the greater tuberosity, and this is the spine of the scapula. And I have told you that the medial border is palpated easily compared to your lateral border, right? So these are the important things which you have to remember. Why lateral border is not easily palpable? Because there are a lot of muscular structures covering it, right? And yeah, it is very, very useful. Anywhere it is useful. And one thing I want you to always examine also is the important nerve here. So what is that important nerve which we are interested in this? So in case of anterior dislocation, or in case of your fracture of the head of the humerus, what is the nerve which is going to be affected? Yes. Which nerve are we worried in case of your shoulder joint? Faster. Yes, very good. It is the axillary nerve. So what is the nerve supply? It supplies what? Axillary nerve supplies which muscle? Faster. It supplies deltoid muscle, right? So deltoid muscle, whenever there is again paralysis of this deltoid, again there would be flattening of the shoulder, right? And which movement deltoid helps in? Deltoid helps in which movement? Primarily it is mainly for yes, very good, abduction. But you have to remember that deltoid helps in every movement except adduction, right? It helps in every movement except adduction, but primarily it is abduction. And what is the sensations? Sensory area, I mean. Axillary nerve sensory distribution. Sensory distribution of the axillary nerve. Again, a patch area, right? A patch of area. Yes, patch of area around the deltoid. This is called as your regimental badge area, right? Mainly near deltoid insertion. So this is regimental badge area. So now we are going to test for sensations over this area, right? So this is also very, very important question they will ask. They will ask you about the deltoid muscle and the supply of the deltoid, that is by the axillary nerve, and the what are its supply. So nerve supply, that is motor, it is mainly deltoid, and sensory, it is mainly the patch of area, that is regimental badge area, right? And what are the conditions where it is usually seen injured? It is mainly the anterior dislocation. So whenever there is anterior dislocations, you have to always examine for the axillary nerve. Whenever there is fracture head of the humerus, again you have to examine the axillary nerve. So that completes your palpation as well, right? And then Coming to the movements, we have discussed this also in detail. So we have flexion, extension, abduction, adduction, internal rotation and external rotation, and also circumduction. And not to forget that scapula also plays an important role in the movement, right? So whenever you want to differentiate, you have to stabilize the scapula and then test for your glenohumeral movement, right? And then we have done about the special test, and then we have done about the shoulder dislocations, which is again a very important topic. So these two are important topics, shoulder dislocations and your rotator cuff, right? Anything else you want to know? So this is our clinical corner setup. So this is where we are bringing up the clinical corner just to excel your clinical knowledge as well, not only theory. And then each subject differently we have clinical corner. And whenever you want to read about particular subjects, for example orthopedics, you can click on that particular subject and then you will have the display of all these important topics which can be asked in your exam, right? What is tardial palsy? Why has that come up now? Tardy is mainly because of the lateral condylar fracture, right? So whenever there is lateral condylar fracture of the humerus, and that will result in a deformity which is called as cubitus valgus. And in that valgus, because of there is a growth on the medial side when compared to the lateral side, there will be stretch of the ulnar nerve, and this will result in your tardy ulnar nerve palsy. Tardy matlab slow. So it will take years for this to develop. So tardy ka matlab it is slow. Onset is very slow. So this is usually seen in the lateral condyle fracture of humerus, where it results in non-union and there could be a deformity, cubitus valgus. And what happens is, because this is a Salter Harris type 4, there will be growth disturbance, right? There will be a growth disturbance. That means the lateral side, the growth will be decreased and there will be growth on the medial side. So this will actually cause the stretch on the ulnar nerve, resulting in what is called the tardy ulnar nerve palsy. Okay, so this is your tardy ulnar nerve palsy. Okay, any other doubts? So thanks a lot for your patience, and I'm extremely sorry for what had happened today regarding the iPad. Yeah, thank you, Gautam. Any other doubts you have regarding the shoulder joint? So what is 𝐒𝐿𝐴𝐶𝐂𝐝? TB shoulder. Sika means dry. So 𝐒𝐿𝐴𝐶𝐂𝐝 is TB shoulder. Sometimes, simply examiner asks what is 𝐒𝐿𝐴𝐶𝐂𝐝, then you can answer it is a name given to TB shoulder, like the Pons spine. Pons spine is TB of the hip, right? Similarly, 𝐒𝐿𝐴𝐶𝐂𝐝 is TB shoulder. Dry. Sika means dry. Right? So that is about it. Yes, very good. Okay, then let's wind up for today. Thank you so much. So any other doubts you have? Zusius Khan, med student. Okay, then take a leave. Thank you. See you all again in the next class. Take care. Bye.